Hello everyone. Today we'll be talking about the coronary collateral circulations, which is one of the important topic and aspect which every student should know. So what is a collateral vessel? Is an anastomotic channel which is known as collateral vessels connect a territory separated by one epicardial coronary artery with that separated by the other one. So that means that supposing this is left anterior descending artery and this is the right coronary artery. Suppose this left anterior descending artery is completely occluded. This will be supplied now by the right coronary artery, where small arteries called as collaterals, which will form a connection here and fill this artery here. So this part is now called as collateral artery. So it has a play an important role in saving the lot of myocardium due to the damage occurred due to the occlusion of the main vessel. So as you can see here, this patient have a acute occlusion of this left anterior descending artery, and this color which you can see here, it shows the amount of myocardium damage which is involved. Now, with patients having a collaterals, you can see that the amount of damage which is shown in the purple color here is very much reduced, as you can see here, because of the availability of the collaterals. So collateral types, coming to the types of collaterals, there are two types in that. First is artery to artery. That means the connection between the major arteries to the another artery. Or it would be either arteriole to arteriole. That is a small branch of that arteriole, that is connections of the arteries or capillaries and arteriole. So arteriole to arterial anastomosis and artery to artery anastomosis. So broad classification wise, these are of four types. First is macrovascular. That means the collateral artery, which we are actually talking about in the coronaries, that where major arteries are connected to each other. Second is microvascular collaterals, intra-artery anastomosis, and arcade arteries. So this corresponds to what is called as for coronary arteries, only we have collateral as well as microvascular collaterals. Collateral arteries is large artery to artery anastomosis, and the heart, it connects major epicardial. It could be either left anterior descending connecting to the RCA or to the left circumflex. So any of the connections could be there. So there is minimal tortuosity and limited remodeling capacity compared to the microvascular collaterals in the normal collateral arteries. So you can see this is the collaterals which you can see here. Microvascular collaterals are arterial to arterial anastomosis, usually less than 100 microns. It is found in crowns of adjacent arterial trees, that is mostly in intramyocardial, highly tortuous, and there is remodel extensively, more variable between individuals, and play a major role in coronary collateral circulation. Coming to native versus recruited collaterals, that is, native collaterals means which are pre-existing, which is also present in healthy myocardium even without obstruction. You have the native collaterals. Recruited collaterals are one which become functional only after there is acute occlusion. So before occlusion, these are never patent. Only after the occlusion of the artery, this comes into picture, and these are called as recruited collaterals. Arteriogenesis, that is remodeling of native vessels into functional arteries. So there was native vessels which was there, which was not much functioning. Now it has came into functioning because of the remodeling, and that is called as arteriogenesis. Key concept is that even small pre-existing collaterals can enlarge and save the myocardium. So what determines the collateral circulation? So the degree of collateralization varies considerably about patients. So that means not every patient will have equal amount of collateral. It varies from patient to patient and also depends upon the amount of disease and the duration of the illness. For many years, ischemia has been believed to be the underlying stimulus. However, no study could directly prove a causative role. So coming to clinical factors that can influence collaterals, first is the amount of degree of coronary stenosis. Suppose the degree of stenosis is 70% and in another patient is 100%. So amount of collateral formation will be higher in patients with 100% stenosis when compared to 70%. Proximal lesion location will have higher chances. Suppose this is the right coronary artery. So occlusion in the proximal part will have higher chances when compared to the occlusion in the distal part somewhere here. Longer duration of symptoms, more the duration, more are the chances, because more will be the time and will be there for the arteriogenesis or for the inflammatory mediators to act. So that's why longer duration of symptoms plays a very important role here. heart rate. Lower heart rate has also been found to have that higher chances of collateral formation and longer duration of lesion occlusion. So why there is lower heart rate, how does it helps is important to consider that during lower heart rate there is more diastolic time. So diastolic time increases if the heart rate is low. That means, as we all know, coronary perfusion which occurs during diastolic phase. So more is the coronary perfusion, more is the chances of collateral formation will be there. So how the collateral forms is there should be a trigger. Any major artery should get blocked and pressure gradient forms between the high pressure and low pressure zone. So supposing this is the coronary artery and this is the stenosis, there is pressure gradient between this zone to this zone. So pressure gradient forms, and this causes increased blood flow through pre-existing collaterals. So suppose there is complete occlusion, there are some collaterals is there. So suddenly this amount of flow suddenly started passing to these collaterals rather than here, and suddenly because of the shear stress on the endothelial cells, it activates the ion channels and endothelial glycocalyx. So endothelium gets activated and it produces adhesion molecules. So I hope you have understand. So supposing this is the collaterals, usually these are very small here. So majority of flow is going in this direction because the diameter is more. Now supposing this gets occluded, this blood has no more chances of going to here. The only way it has can go is it go through the collaterals here now. So this collateral will suddenly face lot amount of blood and there will be stress on this vessel because a lot of blood is going here into the collateral arteries and their endothelium gets activated and produces adhesion molecules like ICAM and VCAM. So whenever there is inflammation has gets activated, more monocytes migrates there and release the growth factors, which is like smooth muscles and nitric oxide. Results is it will lead to functional arteriogenesis. So coming to classification of collateral arteries, there is important classification which was mentioned is the Rentrop and Werner classification of coronary collateral circulation. So Rentrop classification is developed for both as well as non-occluded arteries, whereas collateral connection grade, it shows the grades into 0, 2, 3, and it also defines differently. So coming to the Rentrop classification, as they say, grade A of Rentrop classification, you can see is Rentrop is usually graded as 0, 1, 2, 3. So Rentrop 0 means that you can see here that there is left anterior descending is completely occluded. And only you can see that the collaterals is formed from RCA. These are the collaterals as you can see here. These are all collaterals. Hardly you can see any filling of the left anterior descending here. So example, so grade 0 means that where there is chronic total occlusion with no visible collaterals from RCA. There is no visible collaterals, that is grade 0. Suppose the collateral is minimally visible, that is grade 1. Grade 2 is collateral from LAD to RCA resulting in partial filling. As you can see here, you can see there is reverse thing which you can see another patient. So you can see from LAD there is partial filling of RCA which is occurring here. And if there is complete filling of occlusion, as you can see here, RCA is completely filling the LAD here. LAD is visible from here to here. This is called as grade D. So when we're talking about the Werner classification, is classified into CC0, 1, and 2. So CC0 means no continuous connection from, you can see there's no continuous connection from LAD to RC. There's no continuous connection as such because LAD itself is not visible. Only thin, some minimal things, collaterals are visible here. CC1 is thread-like connections. You can see there is thread-like connections which is there between the LAD and the RCA. As you can see, this filling of RCA which is coming from the LAD. And grade C is called as CC2 is called epicardial. Like it is like side branch. Like as you can see here, this has collateral has formed from this RCA to this LAD. In between them, you can see here this vessel almost looks like a normal coronary artery. So this is that size. So epicardial size. So CC1 is almost like invisible. CC2 you can see is thread-like, and CC3 is like complete vessel. Like as you can see, this is the CC3 type. So what is the clinical significance? So earlier view was that if collaterals often are incapable of restoring normal flow, sometimes thought to indicate worse prognosis, marker of severe CAD. Inconsistent findings across studies, partly due to crude angiographic assessment. So benefit during acute infarction is that it preserves myocardial function, because if there is complete occlusion also, a lot of myocardium can be saved if there is a lot of collaterals present. It limits the infarct size, favorably influences post-infarct remodeling, and associated with less need for IABP after PCA. Let's talk about the coronary collaterals in chronic total occlusion. What is the role of collaterals? It maintains the myocardial viability, improves LV function, and also can be an important route for retrograde PCI access. So assessment of collateral function in CTO. So supposing that whether you can use this collateral artery as a guide for intervention in CTO or not, that is also a few criteria has to be met by the collateral arteries. Otherwise, you cannot use it. So collateral circulation in CTO is predominantly systolic and provides only about 50% of normal antegrade coronary flow. This means collaterals rarely restore full perfusion. Their adequacy needs to be quantified rather than judged angiographically. So there are two index which is talked about. One is called as collateral flow index. It quantifies flow via collaterals to the ischemic region as a fraction of normal vessel flow. So it compares the flow into the collaterals when compared to the normal flow, and it grades like that. If this CFI, it is measured using intracoronary flow velocity, or pressure measurements are taken distal to the occlusion with a pressure flow wire, while antegrade flow is blocked. So if the flow is more than CFI is more than 0.4, generally prevents ischemia at rest. If it is less than 0.5, independently protects higher long-term cardiac mortality. So criteria for interventional collateral channel suitability, whether this collateral suits for the intervention or not. First is operator factor. The operator should have a previous successful experience in collateral channel crossing is the primary determinant of suitability. Second, depend on what is the type of collateral you have. Septal collaterals have higher chances of success in intervention when compared to epicardial and bypass graft. Channel tortuosity, epicardial collateral. Suppose there are more than two sharp curves within 2 millimeters. If there is more than two sharp curves are there. So suppose this is one curve and there is another curve which is forming here within the 2 millimeters. If it is there, then there are higher chances of failure is there. Septal collaterals, there is more than one sharp curve that fails to uncoil in diastole. So that also, and higher frequency curve, more than 180-degree bend within a segment of less than 3 times the vessel diameter is also have high chances of failure. So channel size should be usually at least minimum of more than 1 millimeters, because microcatheter cannot pass safely if it is less than 1 millimeter. Channel length, very long collaterals are difficult to traverse. So suppose more the channel length, collaterals are more longer, higher will be the difficulty chances. Channel entry, adverse if entry angle is less than 45 degrees. Suppose this is RCA, and if this angle is, supposing it is less than 45 degrees, suppose it is any collateral arises like this, so angle becomes less. If it is less than 45 degree, crossing a wire from here and going in this direction, it becomes very difficult. So if the angle is more than 45 degree, then it becomes very much suitable for that. So you can see here an optimal collateral channel should be like this. The angle is more than 90 degree. So easily wire from here can be crossed here. And clear connection side branch, no tortuosity. There's no tortuosity, no bifurcation. And also the exit should have a more than 90 degrees. So donor exit, as you can see here, the wire will again easily can go into this artery for intervention. So that's why higher chances of success here. Thank you.